Okay, thank you for watching part one. Here's part two. I just want to talk a little bit more and just show you kind of a visual picture of each one of those kinds of fluids and how they relate, remember, to the blood plasma. So hypotonic solution. This is a solution where there's less solute and more water compared to the blood plasma or inside of our cells, where we have more solute and less water. So we're more concentrated within, and we want to help kind of dilute this down with our fluids. So with this fluid, when we're giving it, we're going to push the water into the cell and dilute the inside of the cell, the inside of our blood plasma, so we can make this closer to an even concentration of solute and water on both sides. So basically, again, this is our hypernatremic patients. So they have too much sodium within their cells, and we want to help dilute this. So this is when we're giving our half normal saline. And again, look at which direction our water's going. When we start, we have a nice even cell, but we're pushing water in just because of our concentration gradients. When we push the water in, we are swelling that cell, so we need to watch for those signs of edema and intervene if we need to. So that's hypotonic. Next, middle of the road, isotonic. This is where our solute and our water are equal on both inside of our cell, our blood, what have you, to the outside, the fluids we're giving. So it's equal. This is our normal saline. This is our lactated ringers. This allows water to flow back and forth. It's going to be equal in both directions. This is for, our maintenance fluids. This is to increase that extracellular fluid volume for our patients that come in that are dehydrated. Finally, we have our hypertonic solution. So this solution has more solutes and less water compared to our blood, which has less solute and more water. So this is our hyponatremic patients. So this is where we want to increase the sodium, for example, level inside of our patient. So the water is going to travel outside, so it becomes more concentrated on the inside of the cell, so we hopefully can change those lab numbers. So this is just a little bit, like I said, more visual picture of each type of fluid. What I like to keep in mind when I'm thinking of this is, how does the fluid relate to my patient inside of their body, inside of their cells? So try to keep that in mind as you're kind of going through these. Next, I want to talk about IV access. When I initially talked, we talked about peripheral access and central line access. So central line, I'm sure several of you have seen different kinds of central lines. Not only is it the one either in the subclavian or the jugular, but you can have a PICC line. A PICC line is a central line. It's just a peripherally inserted central catheter. We can have implanted infusion ports. So a lot of patients that are on long-term medications or pretty caustic medications, for example, like a chemo patient, will have these implanted infusion ports. And I'll show a little bit more about that here in just a second. With these central lines as well, we can give medications, and generally you can draw blood from them as well. Also, we have obviously our peripheral IV access that we'll be working on in SimLab this week. So central lines, like I talked about, the non-tunneled catheter. So this is placed through an incision. Generally, a physician would be placing these. Here it's either, this is jugular, or you can do subclavian, so it's just right below the subclavian or your clavicle. This is used for short-term needs in acute care settings. So if we have a ICU patient, a lot of times they'll have a central line just because, as you can see here, there's multiple lumens that we're able to infuse different medications in, and it is a bigger catheter, so we are able to more safely infuse different medications that way as well. Then we also have a tunneled catheter. This is it's called a Hickman. It's used kind of more for long-term needs. Again, it's very similar to like a port, but this is tunneled through the subcutaneous tissue, and it is anchored in place. So you'll see those sometimes as well. Usually not as often. I would say the majority, if you have an acute patient, you'll see the central line. If you have a more chronic infusion patient, I would say they'd either have a PICC line or an implanted port they'd have to access. There's also the PICC line, like I mentioned. This is inserted into the vein in the arm, usually the brachial vein, as you can see here. This can be used for longer term. There's a lower infection rate and a decreased cost with this versus like a port or something like that. As nurses, we just want to make sure we don't use the arm with a PICC line to take blood pressures or draw blood out of either. When we do see patients like this, we just kind of want to make sure that the site looks good. We need to make sure if we're doing dressing changes that we have the same amount of catheter outside of the skin as the original PICC team put in. So there's actually a special PICC team that comes and puts these in. Here in McCook, we have 2 nurses that have gone and done training to put these in specifically. So sometimes you will see these, this one here is only a single lumen, but you are able to have like a double or even a triple lumen. So you can give those high rate medications, more caustic medications through this to save your patient. So this is an implanted port. Here's a good example of what it looks like in a patient. Sometimes with your skinnier patients, you're able to see their port just staring at their chest. Sometimes you have to feel around a little bit more to find where you're headed for. And then sometimes they can be kind of tricky to get into. So it's definitely an art to access these ports. These are the different kinds of ports that are able to be placed. The more common ones that I have seen are kind of these triangulated ones with these little dots. They're kind of raised. So as you palpate the skin, you kind of feel for these 3 dots. And when you go to access, you're going to kind of aim for the right in the middle. I've also kind of seen this round port, as you see here in this patient's chest. It's easy to access too. You just need to make sure you hit the center. So this port is hooked up to the catheter, as you can see here, and then it's threaded through the blood vessel, basically exactly where a central line catheter would go. So what we're aiming for is just to the very edge of the superior vena cava. So these ports are surgically implanted. It's connected within the subcutaneous tissue, usually on the upper chest. It can be on the left or the right side. And we access the port as needed with a specific sterile procedure. And we won't go into that right now, but just so you know, it is a very sterile procedure to enter into this because obviously it is going into a central vein. Peripheral access, I just want you guys to watch this video here really quick. I think it gives you a good idea, kind of a down and dirty version of inserting an IV if you've had any if you've ever tried to insert an IV yourself.
At real world application, neat.
Alright guys, so like you said, we're going to go ahead and show you this quick process here. The key to success is preparation. That's what we've done. This is a kit that I make every morning on shift. Makes things a lot easier. It contains everything that you need. Your tourniquet, TEG, lock, flush, which has already been done, cleared the air to the line, catheter, which is already open, and obviously your TEG, which is already broken, swab, gauze, pieces of tape down there as well. So we're going to go ahead and apply our tourniquet. Up here, move the shirt just a touch. A little tight. Alrighty. As you see, he's got a couple good spots already. It's all about, sometimes, especially with the ACs, what you feel, not what you see. So you feel that's plump. You can just see that little bulge there as well. So what we're going to go ahead and do, take our swab, like that, swab the site, in and out, 30 seconds as they teach you in school. We're going to go ahead and take our cath, which has already been open. If you have your crew around, tell them, sharp out, obviously. Shallow. In. Break your seal. And you're going to go ahead and tamp it all off. Apply the lock, which you prepared earlier. Twist. You go ahead and flush. take your tag, apply it over the hub as well as the catheter site, trash your flush, get that going, lock it, just in case they have high blood pressure to kind of blood backs up. Take your tape, seal it, and you're done.
Alright guys, there you have it.
Okay, so like I said, really quick, down and dirty insertion of a peripheral catheter for IV access. It's definitely a work of art. You'll definitely learn tips and tricks along the way. The biggest hints I can give new nurses when they start IVs is making sure that, one, you're applying enough tension to the force or to the skin before you place it. And then just, not being nervous. I know it's easier said than done, but you guys will get practice with that this week. If you see your Perry and Potter book, your skill 42-1 on page 967 will kind of walk you through that as well, more in depth, and especially with kind of interventions and troubleshooting ideas there as well. So here's kind of my list that I kind of go through when I'm starting my IVs. So you're going to obtain all your equipment, obviously. Every facility is a little bit different. Don your PPE, obviously, after washing your hands, making sure you're walking your patient through that, telling them what you're doing. Tie your tourniquet above your site. You can either tie it on the upper arm, or if you're looking for more like a hand-wrist vein, you can always tie it just distal to the elbow as well. Then you're going to look for your site for your venipuncture using palpation. Like the guy said on the video, go by feel, not necessarily by sight. And what I've been taught, I actually was a phlebotomist for 6 years, use your non-dominant hand to palpate. That way it gets more sensitive, and when you're in trying to get your IV access, and if you have to readjust a little bit, you'll have that non-dominant hand to do your palpation. So once you find your site, go ahead and clean that site up with some alcohol. And then here's one of the biggest points that I like to make to new nurses. Like I said, when you go to insert your catheter, make sure you anchor the site really well. I like to anchor above and below my site. I feel like that kind of anchors the vein itself a little bit easier too. You're going to insert the catheter at roughly 30 degrees. And then once you have a flash of blood appear in your chamber, you kind of stop advancing your needle, go ahead and advance the catheter off of the needle into the vein, activate your safety on the needle, and then actually some IV catheters will, the guy mentioned to tamponade off your IV catheter. Some of them will already do that for you. Sometimes you have to apply manual pressure. Once you have that done, apply your flush and go ahead and flush the site. I don't take my flush off until I've applied my Tegaderm and taped it, just to make sure that my IV is not too positional. That way I can give it a final flush. So that's my my piece on IV fluid therapy, IV access. I hope you guys learned a lot, and I look forward to seeing you in class a few times, and then a few of you in clinical as well. Please email me, let me know if you have any questions. My email address is ashley.vontz, VONTZ, @unmc.edu. Thanks, guys.